Hi,
Hi.
I'm Carl with Star Care, for those that haven't met me before. I've worked a little ICU, ER, cath lab, flight, paramedic, just a little bit of everything. So this is pretty informal, so if you have any questions, just stop me. If something's not making sense, or if I'm going too fast, or if I'm being too basic, tell me to hurry up. So with that, we'll get started and we'll cruise along. Pretty much on this, when we looked at sepsis, I guess when I started this, they asked me to put this presentation together. I thought, oh, it's not that big a deal. But the more I looked at the numbers and looked at the whole picture, it is a huge deal. And it's a lot larger than what we thought it was. So some of the things we're going to do is look at the criteria or the diagnosis for systemic inflammatory response syndrome. And then look at the 3 different stages of sepsis from the very start as it goes through the different stages and goes through it. And then we'll look at some of the signs and symptoms of a patient that's compensating and those that are decompensating. And then look at the different treatment and then transport for it. So it's common and deadly, and the incidence is expected to rise. It's the largest growth in health costs from 1995 to 2005, and that's pretty significant when we show you the numbers. It's the 4th largest expenditure for Medicare and Medicaid, which we know is a fair amount of our patients. And then, when you look at reimbursement and how that affects everything, so if we can treat it quickly, we can shorten their length of stay, actually we end up with a better outcome in the whole thing. So why sepsis? If we look at this here chart here, maybe this will give us a little better idea. Look at the incidence of AIDS, polio, breast cancer, CHF. Look at sepsis. You look at the mortality, AIDS, breast cancer, AMI is about equal to severe sepsis. So we don't think of it so much, and it's not just when we look at the population that it's adults. Sometimes it's pediatrics. This last winter, last fall, we went and flew out to pick up a little pediatric that it was significant. I mean, I've flown some Stephen Johnson syndromes, this one was meningitis, and to get on those quickly and recognize them is really paramount that we get IVs going, large bore IVs, fluids on board, and the most critical thing is to get antibiotics started early on. This particular patient that I was referring to, we went and picked up from a rural EMS squad. That one there, we actually stopped at the closest hospital, large hospital, to get antibiotics going, and then flew them on to Children's because of the time factor for that. So when we kind of look at the age, this just kind of to break it down a little bit. This is the incidence by age. You got a few down here at 1 to 5-year-old. Then it goes down. Then it's time to jumps up to around the 35, 40, kind of cruises flat, and then it really goes up in that age group. So we can kind of see where our numbers are as far as the numbers per thousand. It's time sensitive. It's kind of like a heart attack or stroke or trauma. It's one of those that we want to jump on, be real aggressive with, get those IV going, large bore, fluids, and antibiotics early on. So what's our goal? What we want to do is we want to improve the care of the patient with severe sepsis through the successful implementation and get early goal-directed therapy. So there's things that we're going to look at, signs and symptoms. Sometimes it's labs, sometimes it's what you see, it's what you get in the history. And then coordinating that between ER, getting them on the floor, and then deciding, is it something that you can handle, or is it something that needs to go into another facility where they're going to end up on, they may end up on the ventilator, they may actually be in ICU for several days to weeks where they get, while they get everything turned back around. So why do you think that sepsis isn't as important as other diseases? Why have we ignored it? Any ideas?
Because I think we can treat any infection or viral with what we have. And we don't look beyond that.
That's probably a good point. Anything else?
Maybe it's rapids or what.
Yeah. Sometimes it's because it's so rapid. And any other ideas? And sometimes it's just subtle. With this kid I was referring to, there was flu in the area. And so when Mom put him to bed that night, she thought that he just had the flu because Tommy wasn't feeling good. He was running a little fever. In the morning, she gets him out of bed, and I'll show you a photo of not him, but somebody similar that I photoed that had all the blotchy spots for the meningitis already. She started off from home with him talking, and by the time she drove 8 miles to the first little town that had an EMS squad, he was unresponsive. And we ended up, they called for a mutual aid with an ALS squad. They intubated him. We met them on the road and slipped him over and then took him on and ended up at Children's Hospital. So when we look at it, just to give you an idea, the definition for systemic inflammatory response syndrome is 2 or more of the following. We've got a temperature greater than 38 Celsius or 100.4. Which really, you think of it like somebody mentioned, doesn't seem that significant, does it? But then also a heart rate greater than 90. And then I always think you throw in these folks that maybe have some type of heart problems, and they may be on beta blockers or calcium channel blockers, so maybe their heart rate won't go up. So that one there we're going to miss maybe. A respiratory rate greater than 20. So they're fighting infection, they're kicked their respiratory rate up to help bring their pH in line, and then or else a white count that's greater than 12,000, or else greater than 10% in mature forms or the bands. So when you think of it, it's kind of ambiguous and it kind of lurks out there, so you need to look at that whole picture of where the process is going and what's happening. The other thing to be looking at is what's their core temperature. This is in pediatrics. In pediatrics, we look at 38.5 or 36 degrees, pretty much the same as adult. But then with pediatrics, since their heart rate varies so much, you want to look more at this. Is their heart rate greater than 2 times the standard deviations that's normal for their age? And also, is their heart respiratory rate? When you think of it, how does it correlate with their age? Are they working hard? And the other thing to think of in pediatrics is that as a child is, usually how do they interacting with their environment? A kid that's not sick, they're always looking around, we always kind of joke, you get one in ER that, yeah, they're talking to mom or their sister's pestering or whatever, and they're interacting. But the ones that don't interact, that are just focused ahead, those are the ones you get really worried about. And those you want to jump on and get IVs. If you can't get IVs, switch to IOs, get fluids on board and go from there, and antibiotics. I just concluded this for reference. That child I picked up, that cap refill was just like that at 5 seconds. You pushed on it, 5 seconds later, it didn't look much better than that. The kid was in trouble already, way down in trouble. Another thing you can look at, and I'm wondering why this is happening here. Let me look at something. I'm going to quick check this setting. Oh, that went too far, didn't it? Let me redo that. Is that better? Now you can see the whole screen. Sorry I had to reset that. So when we look at pediatrics, if it's mild, 3 to 5%, their heart rate still feels good and strong because they're compensating. Systolic pressure is all good. They may be slightly dry or tacky in their mucosa. Otherwise, their anterior fontanelle, their skin turgor, all that. They may just have a little reduced urine output and a little bit of increased thirst. Moderate, 6 to 9%. These here, their heart rate's up, they're trying to compensate, their respiratory rate is up, they may have dry mucosa, and then their anterior fontanelle is depressed, their eyes may be a little sunken. And a lot of times I always say, looking at these children is that these children generally a lot of times these children, if you look in their eyes, I always say looking in a child's eyes tells a story. Because how are they interacting with you? Did they look like they're not focusing well? Did they look a little glassy-eyed and just kind of kick back? Urine output, you can always ask about that. What they're doing as far as if they're peeing normally, and then also are they listless or irritable? Just kind of grumpy at the world. When it gets severe, and you think of this is only a 10% volume depletion on kids. Then their peripheral pulses are weak or absent. Their systolic pressure drops because they can't, even though they're still tachy, but they can't keep up, so their pressure's dropping. They're parched mucosa, markedly sunken. You can get tinting on their skin, and then they may start to turn a little bit of blue around their lips and around their eyes. And these kids are generally just like prone to grunting or lethargy. So why does a kid grunt? You know, if they come in trouble respiratory-wise, why does a kid grunt? What are they doing? Pardon me? Push out, but they're doing something else respiratory-wise.
Keeping their alveoli open.
Yeah, keep their alveoli open. Because when we put them on the ventilator, we put them on PEEP, right? To keep the alveoli open. Well, the kids will do that automatically. They start grunting. And that they're building PEEP so they can get as much oxygen across as they can. And so that's another big sign that if they're grunting, they're about ready to crash on you. You need to be real aggressive with them. So when we look at the stages of sepsis, the conference definition on this is you look at SIRS, what we just looked at, plus you look at a cultured documented infection. But if you think that you have a reasonable expectation that the child is in sepsis or going there, don't wait for the culture to come back. Just get them antibiotics on board and get the big guns going, because that's the important thing to stop it. Severe sepsis, then you've already started to see one of your organs shut down. Maybe their kidneys, maybe their liver. You're seeing the lactic acidosis build up. And we'll look at that a little bit too, because that's a huge indicator in sepsis. Because when we've tried to compensate, the heart rate's gone up, the respiratory rate's gone up, and they can't keep up, they start building up lactic acidosis. When your lactic acid goes up, it's really a really good indicator that there's a correlation with that. Oliguria, and then also your mental status changes. So in sepsis, you've got 2 out of 4 of those that you've got, plus you've got the infection going on. So even if it's suspected or documented, this is what that kid's legs looked like when I got him. And he was covered that all the way, torso everywhere. And that's not a good sign, because then you know that the capillaries have opened up, some of them have locked open, and they may not shut again. And those kids are the really sick ones, because they've got so many exotoxins that go in there that it's already hurting their heart muscle. It doesn't pump as effective because of all the exotoxins, and it's hurting all their metabolic processes. Then you look at it, do they have a pneumonia? Have they been on some other anti-infective therapy? If you're looking at geriatrics, have they had some round of, let's say, some type of cancer treatment that has dropped their immune system? Another one to keep in the back of your mind, we've seen a few that have been, let's say they went and had some type of knee surgery or some other orthopedic surgery, and they were doing relatively well, and then they developed like a pus pocket or some other infection, and they've been treating and working with that, and then all of a sudden that some organism went wild and took them down. So when you're getting your history, if you pick up some of those things, those are kind of key indicators that you want to be thinking in the back of your mind. Is there sepsis starting to go on here? What's going on with this person? Or like it mentions here, a perforated viscus in the Okay, and severe sepsis, the other thing is when you look at your organ dysfunctions, are they decompensating respiratory wise? Did they have a pneumonia going on? Is it cardiovascular that almost looks like it's bordering an MI event that's coinciding with this? They have kidneys shutting down. Hematologic, do they have a roaring infection? Metabolic or liver? And then also your CNS, what's it's doing. So you can look at any one of those as an organ dysfunction. So in adult septic shock, one of the definitions is hypotension. So you give a couple liters of fluid and you can't seem to gain on that blood pressure. It just kind of sits there. And their heart rate doesn't come down, their respiratory rate doesn't come down, and it just sits there. Then if you pull lactate, and if you pull an ABG, does yours come back with the lactate on it, or is that a special order? It doesn't come back? Okay. Because if you can, either that or order a lactate and see if it is. Because if it's less, that's actually backwards, because it should be a lactate greater than 4. Then you've got hypoperfusion, and it's starting to go up. This here is just a picture of E. coli, what it looks like at the with the microscope. Are you needing the handouts and all that?
I'm sorry, I'm not going to get it in video.
Okay. Oh, sorry, there's a pin.
Sorry,
Okay, and then on pediatrics, we all know that when we have a pediatric that's in trouble, we give them like a 20 ml per kg bolus of fluids. And so if you give them 2 of those in less than an hour and they don't turn around, you've got something else going on. So then what are we going to do? What are we going to do to maintain their blood pressure? Do we give them more fluid or do we start a vasopressor? What's your thoughts? Pardon me?
probably do a vasopressor if we're not getting fluid in the mouth.
Okay, what do you think? Everybody agree or not?
Because that'll be more, he'll have fluid to pump around and his heart's not effective already.
Really, there's not a right or a wrong answer.
So give me both.
Or you can do both. Because a lot of times we'll push fluids, but if their pressure is low, that they're hypoperfused, and their heart rate, that they're not getting good perfusion, and that's changing their mental status, or you're not perfusing their kidneys, that's just adding insult. So maybe you'll want to start dopamine, dobutamine, and we'll talk about this a little bit. In adults, a lot of times we're doing like Levophed or a norepinephrine. It clamps down peripherally, it kicks up the heart rate, but it doesn't cause as much tachycardia as dopamine. On pediatrics, epinephrine works really well. Start them on an epi-drip. And sometimes I've seen like on septic patients given up to 13 liters of fluid to an adult. I mean, they look like the Pillsbury Doughboy the next day, there's not a doubt. But on the other hand, if you get that tank full, they have a really good cardiac output, and once they start turning around, then they'll start just getting rid of that fluid. And you can give them Bumix or Lasix, and you can get rid of that fluid. Once they start turning around, you get a handle on that infection. So that's not a huge thing to worry about. A lot of times, by that time, they'll put in a central line so they can measure their preload and afterload. But the biggest key thing is to perfuse the organs and give fluids, and then as you need to, you can back off on the vasopressors. So in septic shock, you've got severe sepsis, you've got a vasopressor-dependent hypotension. If you don't fix it, you're going to end up in cardiac arrest. So you keep pushing fluids, get those antibiotics on board, because the antibiotics is what's going to stop that whole infective process. And then the other things will start correcting. Then you've got to worry about, can we keep those kidneys alive and keep the perfusion going? The other thing with these folks, it's a good thing if you end up intubating them to sedate them well and paralyze them. That way they're not, I'm sorry, I'm walking near you. You just pushed me aside. Anyway, because if you don't, with them struggling, they're using more of their energy to do that than they are to get well, and you want to conserve all that. So sedation and paralytics are a good thing. Keep them well sedated so they don't remember it, give them the benzos, and then go that route. So some of the predisposing factors that we can look for: age extremes, really young or really old. Are they immunosuppressed? We talked to that of some type of drugs or therapy because of AIDS, cancer, or something else. Do they have some injury or inflammation, some surgery or invasive procedure in the past? Maybe they have malnutrition. They've been dependent on alcohol or something else. Their diet hasn't been balanced. Prolonged intubation, those with the ventilator-associated pneumonia are susceptible to it, or just a chronic illness. So in the pathophys of sepsis, we're going to look at a few things. There's tissue injury and all the pathogens from the particular bacteria that's caused it. That triggers the release of all the pro-inflammatory mediators that want to clear it out. They're fighting it, trying to get rid of it. And this excessive response just gets, I always say it's kind of like when it's going into a battlefield and you kill a certain amount of the folks that are causing the trouble, but you've got all the bloodshed and everything that goes with it that's starting to flood all the capillaries downstream. So then that causes a blunted effect, because when you change the pH, the heart doesn't pump as effective, and so we end up with a whole, like a domino effect of things that go on. There may be direct damage to the endothelium, and then also it's a cascade that's really difficult to stop. So in this is just a quick diagram to kind of reinforce that a little bit. You got your infection, you got the mediators, they kick back, then you've got the balance where it tries to get with the anti-inflammatories, you got the inflammation, but that wins out until we get those antibiotics on board. The other thing that, with this inflammation, is that by hydrating them well, we think, well, 8-10 liters on an adult is a lot. But on the other hand, if we keep their kidneys going and we're diluting it, it helps the kidneys flush it out, and it actually helps the whole process. So you kind of just wade through that and give it time to go through. Because sometimes I've seen it, I don't know if you've ever seen anybody that's intubated that's had that much fluid. The sclera on their eyes, I mean, it's like huge. On those folks, it's best to use some type of eye lubricant, or else just put wet gauze over them so they don't dry out or anything and cause some corneal scratching or something down the road. In the coagulation cascade, then it wants to form a clot to isolate that antigen. And when it does, then it drops circulation to those tissues. But on the other hand, that's a good thing, so it isolates it. The body can destroy that pathogen. If we give the antibiotics, that helps that. It breaks down that clot, then you got the fibrinolysis that's inhibited. But that coagulation wins out. And then you see that purpura. Those are all that coagulation, because it's trying to isolate that throughout the body. And that's what causes all the purpura, like meningitis, Stevens-Johnson syndrome, and those type of things, especially in pediatrics. It's really pronounced. This here is just to kind of give you a little picture of what the microvascular blood flow, how it's impaired in severe sepsis. You got your venous blood down here, your arterial blood coming in at 98%. As it comes through, see how the clots form. So this tissue isn't getting oxygenated at all. Here it's just using a little bit, coming out 94. Here, normal tissue is burning up and it's dropping out 65, and then you're mixing here. That's why getting all that fluid on board dilutes everything. Once this clot is taken care of, just think when this opens back up and the body's after it's destroyed that and you've started to heal, then all this is going to be dumping fluids into there. And so that's why getting a lot of fluid on board isn't a bad plan. So the balance is all upset and the whole response goes systemic. There's excess coagulation, exaggerated inflammation, and then impaired fibrinolysis. So this is just to kind of give you a little picture how on a continuum, if you look at it, there's no systemic inflammatory disease. if there's 2 of them, here's what your mortality percent, it goes up to 7%. If you got 3 of them, the mortality goes to 10%, 4 of them, 17%, and then you've got sepsis at 16. If it's severe sepsis where you got an organ starting to fail, then you go to 20%, and in septic shock, like we've seen with the meningitis or the folks that are really, their pressures just totally went off the bottom, those folks have a 45, and some literature will actually say up to 60% mortality. So how do I decide who's really sick? How do you figure that out? Any thoughts? So when we're screening, we look at our temp like we looked at earlier. Is it greater than 100.4? Or is it low? Why would it be low? Any thoughts? Why would somebody with an infection go cold when a fever and infection usually makes you go warm? Any thoughts? You can guess, I don't care.
Shock, you're going to
Pardon me?
They're close to death?
They are. Okay, so what they've done is first their temperature went up. They were hot. Their white cell count went up. If you'd have pulled labs in, it was through the ceiling. They thought they could get by at home. Well, if they don't get treatment, it just keeps burning the white count. So when they come in, you get them, their white count may look normal, or it may actually be low, and their temperature is down to 96 points. They went from the warm stages of shock, where they were fighting it, where their body was doing everything it could. It used up all its reserves. It's used its white count. Everything's burned up. And then it's went to the cold stages. And in the cold stages is when you really worry, because then it's twice as hard to turn them around. Because then you have to be very aggressive, as somebody mentioned earlier, with your vasopressors, is get fluids on board and get that pressure back up, so these folks, you start perfusing the kidneys and help them everything you can. These people end up on mechanical ventilation, and they've got greater than 10% bands. They're burning everything off. They can't produce it fast enough, and switching everything over. And then in sepsis, you've got 2 out of the 4 of the SIRS criteria, and then you've got to confirm, or else just a suspected infection. Does that kind of make a little sense then? So in septic shock, these have the severe sepsis, the hypotension, they're going to that cold stage. Their BP is less than 90, or they've got a MAP that's less than 70, even though we've given them several liters of fluid, and in pediatrics, the 220 milk boluses. And then we may have them on vasopressors, and we still can't hold them up. These are really sick. So those are the one that's critical to find out what organism it is, or else get them on really broad spectrum antibiotics, or get them on some big kicker antibiotics that are going to take care of a lot of different spectrums, or several of them, to get them turned around. So signs and symptoms when they're in septic shock: they may have rigors, they may have the grunting, mental confusion, irritability. They may be telling the family says, well, they're not themselves, they're irritable. Like we talked to the petechiae or the purpura, mottled extremities, lethargy, kids yell poor feeding, and the bulging sunken fontanelle, decreased muscle tone. And then don't forget with pediatrics to check your hypoglycemia, make sure that you get some glucose in their fluids, especially on some of these, because like meningitis and them eat up glucose. That's one of their main feeders, is what they're feeding on. And so you want to be really cognizant of that in neonates and infants. Check their glucose levels, and then replenishing is needed. Sometimes on adults, you almost see it the other way, that you may actually put them on insulin to kind of balance that whole thing, and keep them on a really tight sliding scale of insulin to keep them where they need to be. So in pediatrics, we talked to the hypotension, reliance on that vasoactive drug. They've got a metabolic acidosis. They've got their heart rate up. They've got their respiratory rate up. Their lactates up. poor urine output, and then a really long cap refill. And their O2 tension or fraction, you've got to keep their O2 really cranked, or else you're losing on there. Your carbon dioxide, they're usually blowing it off. And then you need greater than 50% FiO2 to keep them, if you're not ventilating them, or else you need to get them on the ventilator. So neuro, they may have a Glasgow less than 11, which I always say that's someone that's not responding to you very well. Platelet count less than 80, or it's a decline of 50% from the highest value that was recorded over the last 3 days. Serum creatinine that's 2 times the upper limit that's normal for their age, or a 2-fold increase in their baseline creatinine, or their total belly is 4 milligrams per deciliter. But that's not applicable, as we know, to newborns because of their liver function. So this chart's in there, that's just to kind of give you an idea of some of these different things that you look for: tachycardia, urine output, creatinine. They may end up on acute dialysis. Your D-dimer is going to be up because you've got this huge infection, and the infection control folks that I've visited with, I was saying it's kind of just one more indicator. It's not like it's a granite stone that here's what it is, but it's just one of those more indicators that you throw in that my D-dimer's up, your PTP is up, platelet count's down, and all that is they're fighting it off. And then your liver enzymes may be 2 times greater than the upper normal limits. So clinically wise, fever, chills, hypotension. And when you look at this list, really is it a lot different than what you think of as flu? And that's what I think makes it kind of subtle. Because down urine output, hypothermia, especially if they're getting into cold stages with the elderly or dialysis patient, hyperventilation, and diaphoretic, and apprehensive, and then also levels changes. Respiratory-wise, you get the tachypnea, your ABGs are off, or abnormal chest radiograph. Just keep in mind that that generally lags a day behind what you hear. Is that if you hear they're going trashy or they're not sounding so good, they're coarse, they're whatever, they're drills, that's generally a day behind. They're restless, anxiety, they just don't feel good, they're antsy, they just want something to happen. The family says too, something's not right with them. And then cyanosis. Cardiovascular wise, you may see some tachycardia, hypotension. If you were to measure their CBP or their preload into their heart, it would be up. If they're well hydrated, poor cap refill, there may be some arrhythmias if they've been in a while and they're starting because of all the exotoxins. They may have some changes in their potassium or their sodium content, and then they may go into cardiac arrest. And those are tough to pull out if they've gone that far. Symptoms: restless, palpitations, anxiety, chest pain, mottling, pale, cool to touch, or diaphoretic. Neuro-wise, they may be disoriented, confused, slight changes in their level of consciousness, agitated, or restless. Renal-wise, their BUN will be up, creatinine's up, down urine output. They may be down to 0.4 mil per kg an hour, less than that, or anuria, or they're less than 50 mils a day. And then we're in trouble. Because how long do the kidneys like that? Not very long, do they? Okay, GI, they may develop an ileus, so if you end up intubating these folks, get a gastric tube down them. They have increased liver function tests. They're hypoglycemic, nausea, vomiting, abdominal distension, and that's because of all the ascites that may be going on because of the infection, change in their bowel sounds, jaundice, or GI bleed. They're just susceptible, and it just adds to it. Hematologic, we talked to this, they're abnormal white count, they have a left shift, thrombocytopenia because of all the endotoxins, they're going to PTB up and then go into DIC, and a lot of bruising and bleeding with that. And sometimes I've seen them to where they actually will like pediatrics, especially you get into the Stevens-Johnson syndrome, some of those that are severe infections, they actually just leak blood. It's that severe on them. Skin, they may just have some cellulitis that looks like little bullous lesions. Their IV sites look like they're swelled up, phlebitis, cyanosis around their mouth, their eyes, peripheral gangrene, and then the purpuric lesions, DIC. This is just another picture of some of the purpuric lesions that you show on these folks. So we talked a little earlier about lactate, and this is just to show you that when you look at the mortality, if you measure their lactate and it was 1.7%, I mean it's less than 2.5, their mortality is only like 1.7%. But if it was in the 2.5 to 4 range, their mortality is probably going to be around the 7.5%. And if you get greater than 4, you're jumping to 18.8. So getting the lactate early on actually is a pretty good prognosis of what's going on. But if we're real aggressive and we can jump on this, we can actually turn these folks in that 4 range. But when they get up around the 8, 12, 18 range, those are the ones that are tough to turn back around. So this just kind of gives you a few studies out there. They looked at the mortality associated with the initial inappropriate therapy, and then they looked at appropriate therapy. And this is just how much difference that by doing the appropriate therapy we can drop their mortality. Because like here we go from almost 40 to less than, or about 15 down here on 35 to 15. This study here with Abram, he went from around 58, dropped it back down around a little 32, 34 range. This Kola, he went from like around the 30, dropped it back to around the 17 range. And this one here with Rello et al., he went from around 90%. And if I understand, when I looked at some of these studies, this was in a big regional facility where they probably got the sickest of the sick. But look at the difference that it made by those that they had treated aggressively with antibiotic therapy. So just a rule of thumb for treatment, 20, 30 mils per kg initial bolus in the first 6 hours, followed by 500 to 1,000 mil boluses over 30 minutes until adequate resuscitation, 6 to 10 liters, and like I said, I've seen more than that. And then your endpoint is to get a MAP that's greater than 65 per year and output at least 0.5 mil per hour. I've seen some infection control docs that will push it higher than that. They want to see 1 to 1.5 just because they said they have better outcomes with the kidneys. And then you get your heart rate less than 110, CVP in the 8 to 12, and then observe for pulmonary edema just because all the fluid's on board. And then if you do, you end up pushing your extra Lasix or else put them on like a dobutamine to strengthen the contractility of the heart and get rid of a little more fluid. So if we look at it as a bundle, we want to do a serum lactate in our labs, get blood cultures prior to antibiotics. But the key thing to remember here is don't delay antibiotics to get blood cultures. If you're having trouble getting blood cultures and you just got this gut feeling, then the blood cultures, then you want to just get the antibiotics on board. It doesn't matter so much about the blood cultures, or don't wait for the results. Fluid resuscitation, keep that MAP greater than 65 so the kidneys stay functional. Broad spectrum. Steroids, maybe. It's really not, I haven't seen any studies lately that's shown that that's really helped. There is a few that's practitioner driven that will give steroids. There's not really good data out there, especially in the last data that steroids really help. But there's some that will try it to see if it works. Tight glucose control, may narrow it down to within 20, 30 points. Keep it really tight. It's been documented at better outcomes if we can keep our glucose tight. And then the other key thing is ventilating these patients is only use a tidal volume of their optimal weight of about 6 to 8 mils per kg. So if you think of it, a 70 kilogram person, you're only going to give them about 400 to 500 meals on a ventilator. You're not bagging them really hard. It's not the key thing. Because by keeping lower pressures, and the inspiratory plateau pressures is pressure after you push the volume in, and then it just sits up before it drops, because you don't want excessive pressures there, and that's why it's said to use a smaller volume. Get it in, let it sit low, and then use a fair amount of PEEP on these folks. You may end with 10, 15 of PEEP, because that's going to give you a better outcome to keep those alveoli open. Once you get them open, you keep them open, and then give your next breath, but use lower tidal volumes. Pediatric just kind of mirrors adult, just to fit their body size, 20 mil per kg till their blood pressure's up. Peripheral cap refills, the key thing with pediatrics, and then look for signs of fluid overload. Rails. If you hear a gallop, if you start hearing that S3, S4, and you hear that gallop in there, that's just a sign you're getting. Another thing that shows up in pediatrics a little quicker is they'll have an enlarged liver. So blood pressure, this here's in your literature, and I'm not going to bore you with all the details, but it's just the rough rule of thumb to keep it within the 5th percentile for the age. The biggest thing I always go by, at least in our work, is I check the peripheral pulses. If I don't have a good peripheral pulse, they need fluid, or they need pressure on board. If I've got a good, strong distal pulse, then I'm comfortable that we've got them hydrated, we've got a good pump going on, and they're okay. Till somebody else can take care of them that's got all the fine tools and the high dollar tools to measure ORS. But if they've got good cap refill, and we've got a good peripheral pulse, if I've got a central pulse, then to me they need a little bit more fluid to get a good distal pulse. And if we reach that, then we're getting where we want to go. Are they warm? Do they have cap refill less than 2 seconds? What's their mental status? And then our urine output, do you notice the difference? Pediatrics keep it at 1 instead of 0.5. And I've seen some folks, the pediatricians, push that even up to 2 on these really sick, to get them to, so they don't trash out their kidneys, to get good flow through there to move the exotoxins from the bacteria until that volume is adequately restored and they're starting to turn around. Vasopressors, no improvement after 60 meals. If you give 3 boluses and you can't get them to turn around, then start a vasoactive. You can start with low dose dopamine. The biggest thing to keep in mind there with dopamine is if you start seeing tachycardia, that's when you want to stop and you want to switch over to epinephrine. Because some folks, for some reason, and I don't know why, it seems like they're more sensitive to dopamine. Adults seem to be the same way, that they go tachycardic and then they're like, you're working their heart at 120, 130, 150. On those folks, then it's better to think, okay, do it on a pediatric, switch to epi, or else add norepi or levofed, or on adults, just go straight to norepi. Because it clamps down well, and they've had really good outcomes. When I first started in this business, it was always a joke because the levofed, it was called levofed. And I have seen black extremities because it clamps down so tight. But we've really had good outcomes by watching how much is on board to get your pressures up. It also strengthens with the heart being insulted with the changes in pH and all the exotoxins on board, that levofed, levofed makes the heart contract harder and faster, and they have better outcomes with it than we have with the dopamine. Okay, transport. You decide what's going to be best. You know, is this patient stable that they can go by ground, or do they need to go by air, or with an RN on board, somebody that can titrate the drips, that can watch them on the vent? The biggest thing we found on the outcomes with these folks is that the vent settings are critical. I know that with the RTs I fly with, I've told them that I have learned so much from them, because as an RN, I think, okay, I've got them comfortable, I got this. But sometimes they'll mention, I know like several times they said, well, you just need just a little more sedation. And I said, I had always thought, well, we need to tweak the ventilator a little bit. Sometimes it's not that. Give just a little more sedation. The ventilator settings were good. And they just, after giving them like another 50 or 100 of fans, or giving them a little Ativan on board, because Verse said sometimes if you're struggling with pressure, Verse will drop your pressure more, and Ativan doesn't seem to be as vasoactive, and you still get the amnesia with it, is that those folks, after doing that, I've learned from my RTs that sometimes will give them that extra little kick, that their oxygenation will go from like a 92, 93 up to the 97%. So those things to keep in mind. Minimize the transport time to get into a tertiary care center, or someone that's got pulmonary, the infectious disease specialist. This just a thank to some of my colleagues that reviewed this thing and when I put this together. In summary, early recognition is huge. You know, so kind of keep it in the back of your mind with these folks. You know, are there something that is amiss? Is their mental status different? Is something not, you know, have they had some surgery? Have they had some infection? Just think of all these things when you get them. Be prompt and aggressive with your treatment. Get the antibiotics on board early. Aggressive fluid resuscitation. If you need to, get the pressors going. And then pulmonary toilet, we talked of increased peak. Airway management, suction them aggressively, and then get them to specialists as needed. Any questions? Comments? Just a collage of photos from across the nation, across the state. Yeah, guess what's in the center? Imagine that in Nebraska. Come get some more candy, and if you give me your evals, I'll trade you out for a continued ed sheet. And if you need the EMS one, let me know, because that's a different one, all right?